Oftentimes these patients will come into the hospital, right? They maybe don't follow very frequently with their primary care because they're younger patients. They don't oftentimes go as much, and then all of a sudden, their shortness of breath. They have, significant shortness of breath. Maybe it was seen by primary care and they gave them antibiotics and nothing happened. It got better, and their shortness of breath got worse, and now they're in the hospital and they have florid metastatic lung cancer. We see that those cases, unfortunately, we see those cases more than we'd like. But that's oftentimes, the younger folks oftentimes come through the hospital. We're diagnosing them in the hospital. I think, certainly there are a couple different things, right? Clinical trial access, and making sure that they have access to cutting edge treatments, right? That's obviously, because that's where practice changing things come from. So that was one way to improve outcomes, right? Biomarker testing is a huge thing in lung cancer, right? And patients oftentimes don't have standard biomarker testing performed. We know based on the data, it's about 50 to 60% of patients with lung cancer that get biomarker testing alone. And then of that, looking to see how many actually get standard biomarker comprehensive molecular testing is even less, right? So there's a disconnect there in terms of understanding, there could be a potential therapeutic that you're not offering a patient that should really have that as first line. That, is huge and will improve outcomes if we can do a better job in biomarker testing across the board. So I think those are two areas in lung cancer specifically, where we can work and improve, and I think we'll have, ramifications on outcome.